All right, we're going to talk about, I believe, endocrine and acid base, I believe is next. Please don't go glassy-eyed. Okay, it really isn't as bad as it seems. So we're going to talk about endocrine and acid base as it pertains to those of us who work in the emergency department. People specialize in glands, and people specialize in acid-base stuff and spend years of their lives studying it and practicing it. We only really need to know a sliver of this stuff, but what we need to know is crucially important. So let's get into sort of the meat of the matter of what we need to know about endocrine and acid base in the emergency department. We're going to start with diabetes, sort of the sugar diseases, and diabetes is rampant. There's the data, it's kind of alarming. The data right now on a child born today in the United States is that 1 in 4 of them will be diabetic by the age of 20. So we better get good at taking care of this. A lot of it's because of obesity and bad diet. It's actually quite remarkable. And this is a lovely little sort of cartoon pictures of the kinds of things that people will have when they have diabetes. And one of the clues for us in the emergency department, if you're a really good practitioner, is if you see a woman who has, or a guy, who has intertriginous candida, or a woman who's had a yeast infection 3 times in the last 6 months, check a sugar. It may very well be their first symptom that they have, that they're actually having problems with diabetes. What we tend to see is either sugar too high and the problems that go with that, or sugar too low and the problems that go with that when it comes to diabetes. We don't usually see the well-controlled person. We tend to see them when they're having trouble. DKA, in and of itself, it's actually kind of a remarkable pathophysiology. You have a problem with insulin, so your sugar goes up and you can't metabolize it, and your liver says, fine, you need more, you can't metabolize it, so your sugar gets high, and you start to pee, because your body's saying, whoa, let's osmotically diurese this, get it out in the urine, let's get what we can out of there. So you get thirsty, and you get basically dehydrated, and your body says, wait, but if I can't use sugar, I need something else to use for metabolism. So it goes right to the fat in your body, and it causes lipolysis. And when it does that, it releases basically ketones, which become eventually keto acids. So in a usually relatively short period of time, this isn't something that tends to develop over weeks. This is something that tends to develop over days. Someone will have some polyuria, some polydipsia, they'll feel kind of gross, then they'll feel a little nauseated because they get ketones. Ketones make you feel kind of sick. Last time you got dehydrated, you probably felt a little queasy, or you were having vomiting. You felt even queasier because you were having basically ketones in your body, and eventually they get metabolized to keto acids. So you get acidotic, and that's when you get really sick. So the manifestations usually, because it's an insulin lack problem, that's the issue. It's an insulin lack. I don't have the insulin, so my sugar builds up, and I don't have the insulin. It tends to be type 1 diabetics that get this. Okay, so it's type 1 diabetics that have problems with ketoacidosis, and children may very well be their very first presentation of diabetes, maybe an episode of ketoacidosis. That's what tends to happen to them. Again, you're dehydrated because your body is trying to pee out all that sugar. So you have an osmotic diuresis. It's basically drawing fluid into your urine, and you get not necessarily rapid breathing. The slide says rapid breathing. You can. So if you have a child who comes in whose respiratory rate is disproportionate, or even an adult whose respiratory rate is disproportionate to what you would expect, or better yet, if you're like that 23-year-old we recently diagnosed in raging DKA, look for Kussmaul breathing. I'm acidotic, okay? I have too much acid in my body. What I want to do is try to blow off some CO2 and see if I can get my acid fixed. So what I end up doing is Kussmaul respirations. Really hyperpnic, really deep, sometimes fast respirations. That's what I'm doing to try to compensate for that acidosis that's happening. And again, we'll talk about acid base a little bit at the end, but that's what I'm doing. As they get sicker, especially kids with their first episode, they'll get more and more lethargic. They can have some belly pain, often feel nauseated and have vomiting. That is sort of how they clinically present. Now, if it's somebody de novo, they're presenting because they have an insulin lack that's inherent. They didn't know they had diabetes, and they're coming in as an insulin lack. Insulin lack is one of the kind of 4 big categories of causes of DKA. It's either because you don't have it yourself, or you're not taking your insulin that you have. So insulin lack is one cause. Infarction/ischemia is another cause. It's things to look for. Infection, really common cause, somebody who's usually well controlled with their diabetes to now go into DKA. And the last is infant. So insulin lack, infection, ischemia, infant, somebody who's pregnant, okay, are the common causes of someone to go into DKA who's usually well controlled. And they're the kind of things that you should be looking for when you diagnose somebody who has DKA. The lab tests that you're going to get, honestly, if you have the ability in your urgent care or emergency department, wherever it is you work, to do urine dips yourself. We can't anymore, it's so irritating. But if you do, if you have somebody who comes in, has a history of diabetes, they do a rapid finger stick glucose that's critically high, you dip a urine that's positive for ketones, that's 97% predictive of DKA. It's wonderful. If it's negative for ketones, that's also very, very negatively predictive. So critically high sugar, urine dip negative for ketones, you're really on target as far as whether it's DKA or not. Eventually, what you're going to need to do is order your regular lab tests. If you think somebody's in DKA, get the tests. Get a CMP, complete metabolic panel. You're going to look for certain things, like look for an anion gap, et cetera. On those, check for BUN, because they're often dehydrated with this. You may want to send urine ketones or serum ketones. You don't have to. You may want to send serum ketones. And the absolutely crucial, the most important lab that you're looking at out there is the potassium. And we'll come back to that in a second. You've got to know the potassium. And if you have bedside testing, point of care testing, we have the iStats, whatever brand you want to use, they're actually really handy. You can do it finger stick glucose, check a potassium really quickly, dip a urine for ketones, and now I have all the information I need to know what to do with that particular individual. Now, other things can happen. They can be dehydrated, so have renal insufficiency. Their amylase and lipase may be up a little bit. That actually goes with DKA, but if it is more, the lipase in particular, is more than 3 times the upper limit of normal, you may be dealing with primary pancreatitis as the issue, so worry about those. Check that white count, worry about infections, kind of things to look for. Check the urine. UTI is really common cause of people to go into DKA. Look for pneumonia. Again, you're looking for insulin lack. Did they take their insulin or not? Infection, ischemia, and are they pregnant? Those are the big triggers for people to be into DKA. One of the things to know is the higher someone's sugar is, what will happen in their body is you can actually end up hyponatremic. That's called pseudo hyponatremia. We'll talk about the sort of electrolyte stuff on another separate talk, but just know that if you have a sugar that's high, you need to correct the serum sodium. So the formula is at the bottom. What's happening is your body, as you get more and more and more sweet, as you become sort of the human piece of candy, what happens is your cells say, ooh, gosh, I need to dilute that out. So some of the fluid comes out of your cells. What happens then is you end up with fluid that's diluting your sodium peripherally, and you end up with pseudo hyponatremia. The correction factor, the formula is right there. Excuse me, but I am having issues with this headphone. Okay. The correction is there. So let me give you an example. If you look at that formula at the bottom, if I had a sugar just randomly, because the numbers are easy, of 1100, the way I would correct my sodium is so say my sugar is 1100 and my sodium is 120. So that's not, ooh, gosh, that's hyponatremic. That must be terrible. Actually, let's see if it really is. I take my 1100, I subtract 100 from that. That gives me 1,000. I divide that by 100. That gives me 10. I multiply that times 1.6. That's 16. I add that back to my measured sodium. My body's real sodium is 136. So I'm not really hyponatremic. That's pseudo hyponatremia. And just as an aside, we'll talk about it when we talk about electrolytes. Anytime you get a low sodium, as something that's measured that comes back to you, you get a lab, it's a low sodium, look at the sugar first. If the sugar's high, make the correction to see if it really is true hyponatremia. It's called pseudo hyponatremia. Now, as far as treating DKA, there's 2 sort of issues that come up with this as far as age-based. New DKA in a kid, or DKA at all, but particularly DKA in the first episode in a kid, is 1% mortality rate. So you take a kid who comes in DKA, especially first episode DKA, their first time they've had it, their mortality rate is 1% across the board, no matter what you do. So 1 in 100 of those children is going to die. The reason it says in there, consider physician involvement on this particular slide is 1 in 100 kids with DKA is going to die. You would like to have fluid management be something that's sort of a group decision on this. And if you're by yourself, that's fine, but just know that this is big, this is huge medical legal territory. Treat the kid appropriately. Hydration is really important. They're always, especially first episode DKA, they are so dry. These kids are little teeny raisins. So get them hydrated appropriately as you know to do. You know if somebody's hypovolemic, get their volume status back up. Start at 10 cc's per kilo aliquots instead of 20 for kids, because you want to get them to the point where they're actually not a little raisin anymore, but you don't want to overshoot. And again, 1 in 100 of those kids is going to die. In adults, they often will come in anywhere between 2 and 5 liters dry because they've been peeing out that extra sugar. Their sugar's gone up. They've been peeing it out. So rehydration often will address some of the problem that they come in with the DKA. It'll help them pee out those ketones. It'll actually help them with their sugar. It actually is a very good first step in adults to give a liter or 2 of saline. Feel free to do so. CHF is a different issue. Just treat that DKA. You don't go charging the medicines yet. Give them fluids. And again, the big danger zone is kids. Kids are the biggest problem with that. And just because their mortality rate is fixed and there's some expert out there that's going to say you did something wrong with your fluids, it's really important to be careful how you do the fluids. Don't keep them too dry, though. Now, insulin, as we all know, insulin, well, heck, it's an insulin lack or their sugar is high. I need to give them insulin. Please, please, please never, ever, ever, ever write for insulin until you know the potassium first. Crucially important piece of information. We treat hyperkalemia with a bolus of insulin, right? We treat it that way. The problem with diet, and that's all great if your sugar is, if your potassium is high. What if your potassium isn't high? It turns out in DKA, most of the time, the measured potassium is elevated because they're so acidotic. About 5% of the time, the measured potassium is low. And if you give that person insulin, you can drive their potassium so low, you can have a clean kill. The other aspect of giving insulin is there's no hurry. You don't have to go crazy giving insulin. Get them hydrated, sure. They'll start to pee out some sugar. Things will start to get a little bit better anyway. You don't have to give insulin right away. Always check that potassium first. And I'll show you, there's a little sort of algorithm I'll show you in a second. But that's critically, critically important. Once you're sure the potassium's okay, or we'll go through the algorithm in a minute, go ahead and give the insulin. You don't have to give a bolus first. There was all this teaching about giving a bolus. People don't get any better any faster by giving a bolus. And the dose is usually about 0.1 unit per kilo per hour. So for a normal adult, you would write 7 units an hour of IV regular insulin. That's what you would do for most of the regular adults. And what you're going to do is continue that infusion, not till their sugar is down to a normal number. You're going to continue it until their acidosis is gone. So the sugar will drop because you're giving insulin. When the sugar hits about 250, add some sugar back. Give them D5, whatever, half normal or normal saline. Give them some sugar so they still have some substrate where they can actually use the insulin as they're now taking their keto acids and clearing them from the body. So the key is not to stop the insulin when the sugar's better. It's to stop the insulin when the ketoacidosis is gone. This algorithm is in your book. This is from the American Diabetic Association. It is a very well thought through algorithm with one exception I have a little bit of problem with on that right side, which I don't think there's really any indication for bicarb in a DKA patient. But that being said, they use very, very low pHs to consider it. Just look at, if you look at that, if you look under the potassium column on that, you're going to notice that the magic number on the potassium is 3.3. Anything under 3.3, please don't give insulin until you get that potassium elevated. Okay, get that potassium replaced. Really, really important. If it's basically between 3.3 and 5, you're going to go ahead and start them on some supplementation, but you can go ahead and start the insulin at the same time. If it's over 5, it's all bets are off. Go ahead and give it. But just be really careful with that. That's critically important when it comes to DKA. Now, the other thing that can happen with your sugar being high, and this happens more in type 2 diabetics that are insulin resistant rather than having no insulin at all. They're insulin resistant. These people will get their sugars high, and they can get their sugar. The highest one I've seen is 2,200. 2,200. I mean, that's like the human rock candy. I mean, it's unbelievable. 2,200. What'll happen with these folks is this takes anywhere from days to weeks. Their sugar sits at 400, then it sits at 500, then there it's at 650, and they finally come in and see you with a sugar of 900, 1,000. Often, if they've had a long time to get there, they're fine. They pee like crazy, they drink like crazy, they're starving all the time, they're hungry, but overall, they're not that sick. They can become comatose. Okay, that's hyperosmolar, non-ketotic state that actually has a coma involved with it. But these people often are very, very high sugars, and they're often very dry. They end up with, because they've been peeing like crazy trying to get rid of all this sugar, they often will end up anywhere between 6 and 10 liters down. Again, it takes longer to get there, so they have more fluid deficit than a DKAer does, who gets sicker because they get acidotic. They get sick. These people don't get acidotic. They just get a whole bunch of sugar in there. So usually not ketotic, usually not acidotic, and your job here basically is get those fluids back up again. So get them tanked up. They're often really dry, and then go ahead and give insulin again. Okay, same thing, but same thing, potassium's an issue. It's not usually as much of an issue in this disorder because acidosis doesn't cloud the picture, but just know that you gotta still check, don't ever give insulin without knowing what the potassium is, even in this. There's another table, by the way, in your handout, I think maybe on the next slide. There's another table in there that is how to look at that. All right, so that's high sugar. What about low sugar? Basically, type 1 diabetics who get low sugar, either it's because they have too much insulin, but more often it's because they're using their sugar for some unknown reason. They either haven't eaten enough, or that, and we've seen that, right? I took my insulin this morning and, ooh, whoops, I skipped lunch. Now I'm feeling kind of queasy and shaky and sweaty. Now my sugar is low. But if they've been totally stable and they're taking their sugar and they're taking their insulin and they're eating just fine and everything is fine, but now their sugar's really low in a type 1 diabetic, you have to worry about something like an infection. Something else is using their sugar, so the bacteria is using their sugar, or their metabolism is up because they're needing that sugar because they're sick, they have an infection. That's a really common cause of hypoglycemia in an insulin-dependent diabetic. What they come in with is central nervous system stuff. They can feel a little anxious, they can be frankly comatose. We've all seen that. Somebody comes in totally out because they have no sugar. And the way to fix that is to give them sugar. If they're awake and alert, give it to them orally. If they're not, go ahead and give it to them IV. You can give them basically D50 IV, whatever it takes to fix it. Type 2 diabetics can get hypoglycemic too. The problem with that, if you think about it, type 1 diabetics take insulin, and most of them take insulin in either a longer-acting form or a short form or both. The short form is gone in 3 hours. The longer-acting form is usually gone in 6 to maybe 12 hours. All of our oral meds are 24 hours or longer. So if I wake up at 10 o'clock in the morning, I've taken my pills this morning for my type 2 diabetes. I skip lunch, I get kind of queasy and I feel terrible and I get shaky and I get sweaty and my sugar is 20. I eat something, but the problem with that is my drug is going to last longer than the sugar that I have just ingested. Hypoglycemia, symptomatic hypoglycemia in somebody on an oral hypoglycemic usually needs at least observation for 23 hours, if not frank admission. And the risk you're running is that person whose sugar dropped at 10 o'clock in the morning, or let's say 5 o'clock in the afternoon, goes to sleep. And while they're asleep, they can't manifest the anxiety, diaphoresis, shakiness that goes with being hypoglycemic. They just fry their brain. So it's really important in people on oral hypoglycemics to keep them around for a while and make sure that that sugar really stays where it needs to be, because often it will still drop. Between meals, it'll still drop. So type 2 diabetics on oral hypoglycemics often need admission. Type 1 diabetics who get hypoglycemic often just need sugar and a little OBS and figuring out why their sugar went down. In all cases, make sure there's no infection going on. The symptoms, again, are all epinephrine mediated. They get tachycardic, et cetera. I'll tell you the group that's hard for us is the diabetic on a beta blocker. We used to not use beta blockers because we were worried that they wouldn't manifest all the symptoms. Because think about it, you get shaky, you get sweaty. All of those are epinephrine driven. They're all basically things that beta blockers might block, which would make their symptoms a little harder to assess. That's why a little bit of anxiety may be all they can do. Beta blockers are great drugs. They really should be used even in diabetics. But just know a diabetic on a beta blocker can be a little harder to assess than a diabetic who's not. Oh, here's your table. This is the table on the hyperosmolar state. It looks very, very similar, in fact, virtually identical to the table that you see for DKA, except it's missing one entire column, which is the pH column. It should miss that column because these people don't get acidemic, so they don't usually have a pH problem. So this is sort of the flow diagram for the hyperosmolar state. All right, that's diabetes. That's a pancreas problem, and that's extraordinarily common, and we all get pretty good at that. How about thyroid? Thyroid is fascinating. So basically you have your little pituitary gland up there in your head that's spitting out thyroid stimulating hormone. But what you have down here is the gland that basically usually is doing its own thing. If it's abnormal, it's doing its own thing. So say somebody develops hypothyroidism. The gland says, I'm done. I'm tired. I don't want to put out any more hormone. My pituitary says, dude, wake up. Do something. So it cranks up my thyroid stimulating hormone. That elevated TSH is because my gland isn't doing its job. That's somebody who's hypothyroid. On the other hand, if my thyroid gland goes rogue, it goes crazy, says, oh, dude, I'm going to crank it out. I'm having a good old time. I'm going to have a case of thyroiditis, hyperthyroidism. Now your pituitary says, oh, I'm done. I don't need to do anything. your TSH goes really, really low. So somebody who, it's the TSH that we use in the emergency department to help determine, is this hypothyroidism or hyperthyroidism based on sort of what level the TSH is. And that's what's followed often in people that get supplements for their thyroid disease. So TSH is crucial for us to help determine low or high thyroid problems. Now I like this little particular chart, other than the fact apparently thyroid disease turns you this completely putrid shade of green. This gives you a nice list of the symptoms that you'll see with either of the two entities. Hyperthyroidism, we do see in the emergency department. They look like they're on cocaine. Okay, my poor cousin, who has never done a drug in his life, basically presented with raging congestive heart failure, and they told him, dude, come on, cough it up. We know you're doing cocaine, you're doing meth, come on, come on, come on. He had raging hyperthyroidism. No one noticed the fact that he'd gotten skinny and he had bulging eyeballs. They all just assumed that he had congestive heart failure with this big old heart because he was doing drugs. He wasn't. He was doing the endogenous drug, which is thyroid. Hyperthyroidism gives you all that jittery stuff. They get a peripheral tremor, they get tachycardia, they get diaphoretic, they lose weight, they get anxious, they can go into new onset AFib. All these things can happen to somebody who's hyperthyroid. That's just hyperthyroidism. But if they're awake, alert, and talking to you, they know where they are, when they are, etc., that's just hyperthyroidism. If, on the other hand, they don't know who they are, or where they are, or when they are, they're altered, you've crossed a line, they're often also febrile. You've now crossed a line into true, honest-to-God thyroid storm. And that is a true emergency. That's something we need to do something to intervene on acutely. Hyperthyroidism in general, I'm a little tachycardic, I've got a little tremor, I'm not feeling so great, I've lost some weight, where there isn't really any major end organ problem, we don't really have to do anything emergently on that, but we do with thyroid storm. That's a different ballgame. What you do with thyroid storm is sort of a manifold thing. And I think about treating thyroid storm as thinking about it from the periphery back. Okay, my gland has done something bad. My gland is putting out way too much thyroid hormone. But what I really want to do, what people die of when they have thyroid storm, is they basically die of cardiovascular collapse. So what I want to do is go from the periphery back. So the first thing I'm going to do is I'm going to give them a beta blocker. And what I'm going to do is that does two things for me. Drops their heart rate, which I really want to do. I want to take the stress off their heart. It'll take care of their tremor if they happen to have it. They will also decrease the conversion of T3 to T4 in the periphery. Great, so I'm already starting to deal with the thyroid itself. Then, and often that's all you need, plus some hydration and making sure that there's not an infection going on, et cetera. So that's often all you need in the emergency setting. What's going to happen is as they go on to treat those, they're going to back their way up. They're going to go to the gland, and they're going to stop release of hormone from the gland. There's several ways of doing that, methimazole and PTU. And then they're going to say, wait a second, I don't even want you making any more hormone. And they'll give iodine, basically, to shut the gland down. You don't give iodine first because it can cause a release of, if we had a radiation exposure right now, we would all take iodine right now. You'd release some hormone, but you'd shut your gland down. You don't want to release any hormone in somebody who's in thyroid storm. So again, start at the periphery and work your way back. For us in the ER, it's hydration, make sure they're not infected, give a beta blocker, make a phone call. Okay, all the other stuff can be done on a less than crucial status as far as thyroid storm. Now, the other end of the spectrum, your gland that's basically given up the ghost, it's a glandular problem. People who have hypothyroidism do get things like weight gain. I think everyone who gains weight would love to have it be their thyroid. Right? Everyone who gains weight, just please let it be my thyroid because I hate dieting. Please, I just need a pill. It doesn't work that way. But overall, just know that they get things like brittle hair, they get constipated, their skin gets kind of thick, they get slow, they get tired, their tongue gets thick. They just kind of slow down. These people, rarely are they truly in coma. But you will see people with true, honest-to-God mixed edema crisis. It never comes out of the blue. It is virtually always in somebody who has a history of hypothyroidism. If it's somebody who comes in, I'll tell you, if you're a rock star emergency practitioner, you have somebody who comes in who has thick skin, brittle hair, bradycardic, they look like they've gained a little weight, they just don't look so good, they're altered, and you look right here and you see a scar. If you pick up on that and you pick up on mixed edema coma, you are a rock star. You are an absolute rock star. People don't get this very often because they have known hypothyroid disease, and even if you stop taking your thyroid medicine today, you're not going to go into a mixed edema coma today. It's going to take weeks. Those hormones stick around for a long time. So you can skip doses, go on vacation for a week, forgot my medicine, pick it up again when I come back, I'm good. This is not a common thing at all for us to see. If you do see it, though, and we've seen it a couple times where I work, by the way, this is what you look like. On the left, he looks like he's kind of a portly guy. He's not. He's a guy who basically needs some thyroid hormone, and now he looks like a normal guy on the right. The treatment for this, first of all, make sure that something didn't trigger them to go into a myxedema coma. Make sure they're not infected. So that's kind of important to do. If they're cold, rewarm them, but passively. You don't have to do anything crazy with that. What you do need to do is, and honestly, it's really rare we have to go crazy giving hormones in these folks, but if they really are bradycardic and it doesn't respond and they are altered and they're really out of it, you may need to treat them. You may need to get some thyroid hormone on board. Please never ever do it without giving some hydrocortisone first. These people, their endocrine system has often slowed down, including their adrenal system has said, you've been slow for a while, you don't need me to kind of ramp up, I'm gonna chill out too. So they're relatively adrenally insufficient. Now I take someone who's relatively adrenal insufficient, who's in a coma, I push thyroid hormone, which is like pushing cocaine. Basically, it's your own body's stimulant. I'm now going to stress a system that has no adrenal axis to be able to hold that up, to be able to support that. So give hydrocortisone first, then you can give the thyroid hormone. So if you ever need to treat this emergently, it's hydrocortisone first, then the thyroid hormone. But often this is done on the phone with a consultant, okay? It's totally fine to do. Often done with a consultant, because this isn't something we do very often. So don't fly by the seat of your pants if you have a question. All right, we're going to spend 4 minutes going over acid-base disorders. Acid-base, honestly, if you're a puzzle person, if you really like logic puzzles and figuring out puzzles, acid-base is fun. Acid-base is really fun. If you're not, it's torture. It's please pull my fingernails out slowly. I hate acid-base. Acid-base is actually relatively simple in its concepts. First of all, emia, alkalemia, acidemia is what the blood is doing. Osis is the process that gets it there. So if you look at that little table on the top of that particular slide, you're going to notice that respiratory acidosis is caused by retaining CO2, driving my pH down. Metabolic acidosis is caused by basically having too much bicarb, or too much acid. So if you look at this table, the osis is the process, the emia is what you're measuring in the blood. Compensation for it. So say I decide I just can't stand, I lose money out there. A guy last night in the Diamond Lounge was watching the Florida-UConn game, which was actually an amazing basketball game, but apparently he must have had money on Florida because they lost by 1 point in the last second. He basically put his hands down on the table, picked a fight with one of the guys who's working for us out there at the table. It's unbelievable. What if he decides he just blew all of his money and he's going to take methanol? That's it, I'm going to overdose on methanol. He's going to get an acidosis from methanol. What's going to happen to that then is if he gets acidotic right now, or let's say our DKA patient, they're acidotic. The way they can make themselves correct right now is respiratory, and that happens fast. So anywhere from minutes to hours, I'm going into DKA, I'm breathing more and more and more because I'm trying to blow off CO2 to correct my acidosis. Versus, I have obstructive sleep apnea. I weigh 450 pounds. I retain CO2. Okay, I don't blow off. My normal CO2 now is 60. The only way my body can correct for that on a metabolic level is through my kidneys, and that takes a while. So metabolic corrections take days to weeks. Respiratory corrections take hours to days. So that's a much more adaptable way to change it. Your blood gas gives you several pieces of information. We talked about the pH earlier, but the pH, again, that's the emia, alkalemia, acidemia, but that has both respiratory and metabolic ways to get there. The PCO2 and the PaO2 basically are measured by that, and the PCO2 is very important for you to make your calculations. And you're going to get a number called the base excess. The only important thing on that slide is the very bottom line. Highlight that. Base excess, how they calculate that, if you want to get into it, it's all good on you, but the reality is if you have a negative base excess more than 3, you have a metabolic acidosis of some sort going on. Okay, that's probably the number that's the most useful on that particular slide. You need 4 lab values to calculate or to figure out what somebody's acid-base status is. You need the pH, again, which is the emia. It's not the process, it's the emia. It's what's in the blood. You need the PCO2, which will tell you what the lungs are doing. You need the bicarb, which will tell you what the kidneys are doing. And then you need that Chem 7, so you actually need a Chem 7, to get that anion gap. You need to calculate an anion gap. So those pieces of information will tell you everything you need to know about somebody's acid-base status. The anion gap you all know very well. It's basically positive things minus negative things. So it's the sodium and the potassium minus the chloride and the bicarb. A normal one is up to 10. Over 10, something's abnormal. And if you really want to get into it, Winter's formula is here for you. And the main reason for Winter's formula is if you have somebody with an acidosis, what you'd like to know is, are the lungs compensating appropriately? So I have DKA. My pH is 7.1. My PCO2 is 11. Is that correct? Is that PCO2 of 11 appropriate? Am I breathing enough? Or better yet, I have DKA. My pH is 7.1. My PCO2 is 32. Now wait a second. If I do my little calculation, my PCO2 should be significantly less than that. It's not. If I end up with a PCO2 that says, no, I have more of what I can blow off still left in my bloodstream, that means that there's a respiratory process going on too. So that would be the opiate overdosed person who's not breathing, who also happens to have DKA. It's basically a triple disorder. It's actually wonderful. You can do all these calculations to figure it out. So this is where the puzzle part is fun. I love this. I love Winter's formula. I do it all the time. But it gives you an idea of, is there something wrong mental status-wise, or is there some other process going on here in addition to what I think is the primary issue? Now, to get to sort of just cut to the chase, you've calculated out what's what. You figure that it's an alkalemia or an acidemia. You've calculated an anion gap. Here's the metabolic acidosis differential, and that is anion gap positive or anion gap negative. Anion gap positive is basically C mud piles. And the reason that the C in the front is added is that we forget certain things, especially this time of year, like carbon monoxide poisoning. Carbon monoxide poisoning causes a metabolic acidosis because I end up unable to use my own oxygen, and at the cellular level, I get a metabolic acidosis. That is the reason C has been put in the front of your usual mud piles. And most of us can recite mud piles in our sleep, methanol, uremia, blah, 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 blah. It's just important to keep this list so that if you end up with somebody with a metabolic acidosis that has an anion gap, you go through this checklist every time. If it's the DKA person, you're kind of done. But they're not diabetic. They didn't drink anything that's a funny alcohol. They're not in renal failure. I'm getting down to very few things that can be causing their acidosis, their metabolic acidosis with an anion gap. So it's worth knowing that list. Now, if you have a metabolic acidosis and there's no anion gap, it's Dr. Fishpucks. Who comes up with these things? Dr. Fishpucks? I don't know. This is a mnemonic that some people use. You can pull it off the web. It's actually used by quite a few people. But it gives you a list of the reasons people will have a metabolic acidosis with a normal anion gap. Most common of those is diarrhea. Okay, I am pooping out bicarb, so therefore I have an acidosis. Or RTA, some of the actual kidney diseases that are going on out there. Here's another sort of, if you like to break it up by why they have it. Is it a kidney problem? Is it an acid load problem? Is it a bicarbonate loss problem? This is another way to look at it. Totally up to you. I like the mnemonics, but this is another way if you like sort of the pathophysiology approach. Now, metabolic alkalosis. That's a different ballgame. And this is basically high pH. I like this as a mnemonic that makes sense. My pH is high. If I have a metabolic alkalosis, this is the differential of this. The reason this is important, let's say I get put on hydrochlorothiazide by my doctor. And I come into the emergency department, and I don't feel good at all. And my pH is 7.55. What's happened is I've gotten really dehydrated, and I've ended up with a metabolic alkalosis because I've got a contraction alkalosis. Same thing happens with somebody who's an NG suction. That's why we don't NG suction people anymore. You're sucking out sodium chloride. What you do is you give them a metabolic alkalosis. That's an unhealthy thing to do. So this is your differential for basically a metabolic alkalosis. It's called high pH. And these last two slides, you have both of them blown up big in your book, are wonderful summaries of acidosis and alkalosis. And it does it all for you. It starts you at what the pH is. It takes you, so for instance, an acidosis takes you right to what's the bicarb. It sort of takes you, I'm not going to walk you through it because you guys can read and it's kind of extensive. But this is a wonderful summary to put it all in one place. All right, that's acid-base disorders. I think it's time for a break. Thanks.